First of all, before starting my presentation, I'd really like to thank you for the invitation. It's a pleasure for me to be here, part of this Congress. It's also a pleasure for me to be here to see so many good professionals, so many good colleagues, but also some very good friends. Future outlook for transcatheter tricuspid valve therapies, and I am going to start with drawings. Drawings coming out from old cardiosurgical manuals, drawings revealing how minimal invasive transcatheter tricuspid valve therapies actually recreate the main principles of cardiosurgical tricuspid valve repair and replacement. And we have, of course, the coaptation devices based on the Alfieri stitch. We have the Cardioband based on the Carpentier annuloplasty. We have the K-clip based on the K procedure, the bicuspidization procedure. And we have a plethora of devices for orthotopic and heterotopic transcatheter tricuspid valve replacement. We have about 35 devices that are waiting at the pipeline, waiting for clinical evidence. My intention today is actually to focus on alternative strategies based on the everyday clinical life in Berlin, and to try to think and rethink how the future landscape may look like. We have here our first patient. We have the typical dilatation of the right atrium, tricuspid annulus, and right ventricle dilatation. We have a patient with HFpEF, with atrial fibrillation. We have a patient with severe to massive tricuspid regurgitation with overlapping features. We did a transthoracal, a transesophageal echocardiography, and at the end we decided for a cardioband. First, we have to understand what is a cardioband. It's a flexible band that is covered by a polyesteric sleeve, and the main idea here is that I want to target first the anterior segment of the tricuspid annulus. I want to move to the posterior segment of the tricuspid annulus. I have to attach using anchors, deploy the band, moving along the hinge point of the tricuspid annulus, contract the band, and at the end, I am reducing annular dimensions, and I can reduce tricuspid regurgitation. Stepwise approach. For a good navigation, I need inflow-outflow view, biplane view. I need also 3D and fast view. I need fluoroscopy, and I have everything. For the deployment of the band here, we have to be careful, so we have two main phases. First of all, the deployment of the first 6 to 8 anchors. And here I want you now to focus on, at the left side of the slide, what we see actually here is the tip of the band that moves from right to left, from anterior to posterior. You can also focus now on the right side, and you see the tip after 2, after 4, 6, 8 anchors. For the second phase, now we are at the posterior segment of the tricuspid annulus. It's a little bit more tricky. What we need here is MPR. What we need here is, Okay. What we need here is fluoroscopic view, because we have to test again and again for RCA proximity and RCA compression. We're moving forward. We have now the adjustment, the most important part, of course, of the whole procedure. I want you to focus again at the left side of the slide. What we see here is that we are contracting the band, we are increasing the sensing, and we are reducing annular dimensions, and at the end, we are treating the tricuspid regurgitation, at least to a great improvement. Here we have another patient. Here is the typical patient with a big gap, with a flail tricuspid regurgitation. Here again, tricuspid regurgitation with overlapping features, and we decided again for a cardioband. Before every cardioband procedure, we need a good CT examination for 3 main reasons. First of all, annular dimensions, RCA proximity, and IVC position. Extremely important for the whole procedure. Here what we see, we are again at the last part of the procedure, adjustment. Again, at the right side, you see improvement of tricuspid regurgitation because I'm increasing the sensing. But I put this slide here actually for the right side because we see how the reduction of the annular dimensions actually has a positive impact on the whole coaptation of the tricuspid leaflets. What are we waiting general from annular devices? Of course, the next generation cardioband comes in the future, but we have also other devices like the MIA system. less invasive procedure. Here we have a thermoplastic elastomer. Here we have low mass polycore anchors. And here we have a bicuspidization technique. So we are plicating only the posterior segment of the tricuspid annulus. Here we have another device, the K-clip, again based on the bicuspidization procedure. Here we're plicating the anterior segment of the annulus. We can use one clip or a second clip. And here we have another device, a Corofix. Because of confidential reasons, I can only show you this picture here. Actually, we're talking about the system. We don't talk about the device. So here we don't use a device. We know that the company has already started with the first attempts for the mitral valve. We are waiting to see the attempts for the tricuspid valve. We know that they are developing the system. And I really put it here because we have to understand we go less invasive, faster, and we are trying to manipulate the tricuspid leaflets as less as possible and the annulus generally. Here we have a single leaflet device attachment after the implantation of a second clip. Here, so it's just mathematics. I mean, if we are doing more and more procedures, even if we are trying to optimize everything, we will have more complications, or we will have complications. So we have to think, and in the future will play a very important role, think and rethink about bailout options, about complication management. And here I have a very nice example. It's already published. We had a patient. We tried with massive tricuspid regurgitation with a big gap. We tried first with 2 triclips. After the second triclip, we had a single leaflet device attachment. And at the end, we decided, because of right heart decompensation signs, we decided for a tric valve. We have 2 valves. They are not identical. There are some differences, one for the IVC, one for the SVC. The most important thing is actually to understand for the IVC, I need actually a shorter skirt because I don't want to block the hepatic veins. And for the SVC, I need a long skirt because I don't want to have a paravalvular leakage. After the implantation of the tric valve, we had a significant improvement of clinical condition. And now we have our last system. We are talking about the pivot system. We have a spacer that I have to implant actually in the vertical aches of the tricuspid annulus. The main idea here is that I'm trying to improve the coaptation to block the tricuspid regurgitation. And the most important thing here is that I'm talking about a short-term implantation like the pivot TR system, and we have the pivot bridge trial, which already started, for about 7 days. So it's like we have to think about a bridge to next therapy, a bridge to optimization. And we have the pivot extend system, the pivot Mandu system, and we have a very good trial, the pivot extend. We are going to use these devices more and more in our valve center. And I'd like to end now my presentation. I could end my presentation and just say that, just in a few words, annuloplasty matters. Combination of therapy, combination of devices matters for complication management or even for rehabilitation procedures. But I really think that I would end here this presentation using these open questions, not direct answers. What's the best device or strategy for a given patient anatomy? Will transcatheter annuloplasty be alternative or adjunctive? Can hybrid or combination strategies improve outcomes? Which are the optimal bailout and complication management strategies? Thank you very much for your attention.
Great. So thank you very much, Dr. Exarchos, for this very important presentation. You have summarized indeed nicely some of the main points of these techniques.